Greetings from PADMA. The PADMA Foundation was established to provide a common forum for the practicing physicians to promote, meet, and to share experience and research observations in the field of diabetes, internal medicine, and other specialties of modern medicine. It is a great pleasure to have the honor of welcoming you to this conference with a difference, named Metabolic Memories, which aims at enlightening physicians and primary care practitioners of Central Travancore on the emerging developments in the field of diabetes. Let's begin. We welcome Dr. Prashant Shankar, consultant in internal medicine and diabetes, Muthoot Hospital, Pathanamthitta, to deliver his speech, Metabolic Memory. Let's catch him early.
Very good morning and warm welcome to all to this CME. As you know, this is the first conference of PADMA Foundation. Without wasting much of time, I'll be going into the first topic. My topic is a different topic which is less commonly discussed in today's meetings. So the topic itself is the name of our conference also. So it's termed metabolic memory. So the scheme for discussion today, the real problem which we are facing today, the risk of developing type 2 diabetes in our people, complications in those patients with diabetes, diabetes in those patients who have already some complications, the challenges which I see as important, metabolic memory, why should we catch them early, and my take-home message. So this is, these are things which you already know. Diabetes is a serious and growing public health problem with reduced life expectancy and increased morbidity. There has been a paradigm shift in the therapeutics and glycemic monitoring, but the presence of macro and microvascular complications still remain an unsolved problem. So coming to the incidence of and prevalence of diabetes, this is the study which was done by Dr. Vijay Kumar and his team himself. I'm not going for the data from the Western world. Our data is entirely different. And Vijay Kumar sir has shown that there has been, over the last 10 years, there has been 60% conversion in patients who were previously having impaired fasting glucose. They were converted to type 2 diabetes. So this was a study done in Vedmani Taluk of Chenganur. And this study also had a prevalence part, which showed that roughly the prevalence of diabetes in this part of the world is 1 in 4. So 1 in 4 persons has diabetes, and alarmingly 1 in 3 persons have pre-diabetes. This is one study which we published in the IDF 2017, where we analyzed patients with type 2 diabetes for peripheral neuropathy. I'm just extracting the data regarding the complications. So we saw that among 671 patients with diabetes with mean age of 60 years, the overall prevalence of complications was 45.8. The peripheral neuropathy was present in almost half of the population. 1/3 of the population had pre-existing cardiovascular disease. Almost a quarter had retinopathy, and increased albumin excretion was seen in 34%. Peripheral arterial disease was slightly less compared to the Western data. It was around 10%. This is the Indian Diabetic Risk Score, which all of you know, which helps us in diagnosing or screening patients for type 2 diabetes. It is a scoring system with 4 parameters. A score of more than 60 is considered as high risk for diabetes, and a score of more than 60 has a high sensitivity and a good specificity for determining undiagnosed diabetes in the community. And the important is that the negative predictive value of 95.1%. So we did a study during the 2017 World Diabetes Day, which the theme was women and diabetes. So we screened all the female staff in our hospital to see the risk of diabetes. So this is the IDRS score. As you can see, it contains 4 parameters: age of the patient, abdominal obesity, physical inactivity, and family history. So we considered females in our study. So this was published in last year's ADA abstract book, 2018. And we did the study among 326 women employees. We found that the IDRS score was more than 60 in 48.7%. You can see the age of the participants. Age was very less. Most of the participants were staff nurses. The mean age is only 33 years. So at that age itself, we have a large number of females who are at risk of getting diabetes. And it was important to see that only 13.5 had a waist circumference which was less than 80 centimeters, which is recommended for Asian people. And more than half had a waist circumference of more than 90 centimeters. And interestingly, 87.4% had sedentary lifestyle. So I am just highlighting the risk factors which are present in our population. And positive family history was present in 45, almost half of the participants, which again shows the high prevalence of diabetes. And we did a screening with the fasting blood sugar in those patients who had a score of more than 60, and we saw that among those patients at high risk of diabetes, already pre-diabetes was present in 26.4% of the females. So again, showing that we have a very huge risk of huge set of patients who are in the pre-diabetic stage or getting to become diabetic. So this is actually one of the slides given by one of the pharma company, which they considered as challenges in management of diabetes. Their challenges were uncontrolled diabetes, high prevalence of obesity, cardiovascular risk, comorbid conditions, hypertension, cardiovascular disease, and CKD. But I will just go through a couple of cases which I feel as the real challenge. This has been presented in other venues also, so some of you might be familiar with these slides. This is a case of primary non-prevention. So 43-year-old male with a history of type 2 he came in August 2016, new onset diabetes, going back to Gulf next day. His A1C was 11.4. His total cholesterol was more than 300, LDL was more than 250, strong family history of cardiovascular disease. He was started on an OHA and statin, advised on the increased risk because of the dyslipidemia, and he was asked to continue the statin, but he never came back, as it often happens. He got admitted to our cardiac unit 2 months ago. He was back from Gulf just 1 day before, again with accelerated hypertension, pulmonary edema, and NSTEMI. Statin was stopped after the first 3 months. He continued the OHA at half the dose. His HbA1c was 8.2. He was advised a coronary angiogram, but he couldn't do it because of the financial constraints. This was his ECG, and this is his lipid profile on review. You can see the LDL is still 264. And this is his echo report, which shows ischemic DCMP, probably ischemic DCMP. So again, a patient who could have been prevented, any event which could have been prevented by providing good primary prevention. This patient was an eligible candidate for statin therapy, missed the statin. Now we have a case of secondary non-prevention. 50-year-old male admitted in 2012, it is not 2017, 2012 with accelerated hypertension, posterior circulation, TIA, and a new onset of diabetes. At that time, the MRI showed multiple small vessel changes. He was started on antihypertensives and statin. He lost on follow-up for 2 years. He came back a few years later with burning chest pain, stopped statin, again stopped antihypertensives. His BP was high, ECG showed ST elevation in the leads, TROPI was elevated. Again referred to the cardiologist. Next day I saw him in the CCU after getting an angioplasty done. So again a case of secondary prevention. So again the patient has skipped the medicine. So these are the things, the common things which are happening in our society, where things could have been prevented by proper management. Again, this is the ECG of the patient. So that was the macrovascular complication. Coming to profiles of 2 patients with microvascular complications, you can see a 73-year-old female, 15 years of diabetes on insulin and OHA, hypertension, dyslipidemia, all the complications are there. But she is on regular follow-up since 2012. The baseline creatinine was 1.5. It rises to 1.8 to 2 whenever she gets an acute episode. But she used to come to the OPD regularly, and she has very good medication adherence, reasonably good HbA1c for her age. And when she came last week, her HbA1c was still well controlled, and her creatinine was 1.43. So even after 5 to 7 years, the patient is on regular follow-up, and she is taking all her medications regularly. So the CKD status has remained status quo, and even though, or it is slightly improved. So that shows that once the patient is on regular follow-up, you may be able to prevent the progression of CKD. Or then on the opposite side, you have a 59-year-old male with diabetes more than 10 years, insulin and OHA, hypertension, dyslipidemia, a smoker, highly irregular and erratic treatment with poor medication adherence. So he came back, his baseline creatinine was 0.7 in 2013. He came back after a gap of 3 years in 2017 with a creatinine of, it is not 0.7, it's 4.3. And again, his creatinine has risen, and he is now on a hemodialysis with frequent complication. You can see the rise in creatinine. In 2013, it is 0.7. It has gone to 1.2. In 2017, when he came, it was 4.3. Suddenly, within 3 months, it went to 9.5. And he has already had an amputation. He is regularly on follow-up in our hospital for dialysis. You can see his HbA1c at the beginning also. It's the 11. It was 11 in 2013. Again 13 in 2017. It is 8.7, but of no use. So this is another challenge which we all are facing. The mixopathies and the other therapies which are there. I think you can remove the video from there. This is another big challenge which we are facing every day in the newspapers. We can see this. And another thing, if you type for diabetes treatment in Kerala, I was expecting Vijay Gopal sir's name or Jyotidev sir's name to come first, but the first name to come is the alternative therapy. And if this was searched yesterday, you can see the quality of the slide is not clear. You can see that all the treatment which you get is not modern medicine, it's all Ayurvedic treatment. So that's where we stand right now. So the challenges which I see as a physician is are these: diagnosing early and avoiding inertia, maintaining treatment adherence, ensuring regular follow-up visits, regular screening for complications, and ensuring proper communication with the patient. So these should be given more priority so that we can prevent the deterioration of diabetes and the onset of complications. So few words about metabolic memory. The concept of metabolic memory came with the DCCT and the EDICT follow-up, which was done in type 1 diabetic patients. So the DCCT had two arms, the standard arm and the intensive arm. So it studied the progression of microvascular complications, and it ended prematurely at the time of 6 years because of the marked difference in the two arms. There was marked difference in the development of microvascular complications in the intensive arm, and all patients were put on intensive therapy after 6.5 years. So that shows that good control decreases complication. And the EDICT trial was the follow-up of the DCCT, which again showed that the initial intensively treated group continued to have lower rates of development of microvascular and subsequent macrovascular complications. So this gave led to the term known as the metabolic memory or the legacy effect. The same thing was seen with the type 2 diabetes patients who were who underwent study in the UK PDS trial. So initial treatment itself, there was reduction in the microvascular complications. But as you can see, the 10-year and even the 20-year follow-up of UK PDS, which was published in 2017, showed that there is a persistent reduction in the microvascular and to some extent macrovascular complication if you control diabetes aggressively during the early part of illness. And better HbA1c control is associated with reduction in microvascular events, and even CV events and mortality were observed 10 years after the trial ended, and even when the HbA1c values converged, the benefit remained. So again, showing the importance of early diagnosis and aggressive treatment in patients with diabetes. So this is the STENO trial, again, which was a landmark trial. This is a 21-year follow-up of the STENO trial, which was published in 2016. I will just read the conclusion. The STENO trial was for 7.8 years. At that time itself, it was showing good reduction in microvascular complication. But the 21-year follow-up was published in 2016, which showed that at the end of 21 years of treatment in patients with microalbuminuria, they demonstrated 7.9 years gain of life. So at the end of 21 years, patient who had a strict glycemic control at the beginning, they lived for approximately 8 years longer than patients who had a poor glycemic control at the initial 7 or 8 years. So again showing the importance of good glycemic control in patients with diabetes early in the course of the disease. So after that, lot of articles have come defining metabolic memory as an epidemiological perspective, the glycemic environment, whether it is a vascular stress, lot of theories have come in. Lot of concepts are there, different mechanisms like mitochondrial DNA damage, protein kinase C activation, all these things are available in the textbooks. I won't go through that. Lot of mechanisms are there. But again, doubts persisted. These are all randomized control trials. Can we extrapolate this to the real world scenario? Is this practical in real world scenario? So then came the study in 2017. This is a diabetes and aging study, the first part of the diabetes and aging study, where they looked at the HbA1c trajectory. We know about the glycemic variability of the in patients with diabetes. This is something related to HbA1c variability. So this study showed that compared to the low stable HbA1c trajectory, that is the blue line you can see at the bottom, these are patients who had a relatively stable HbA1c from the onset till 10 years. 10 years follow-up was there. And compared to the low stable HbA1c trajectory, the other 10-year HbA1c trajectories were associated with higher risk of microvascular disease and mortality independent of the 10-year HbA1c average. So stable low HbA1c values may confer additional benefit above and beyond controlling the modifiable cardiovascular risk factors for average glycemic control. More interestingly, the study showed that nearly 30% increased risk of death associated with high decreasing early trajectory. That is the highest initial HbA1c level. That is the red line which you can see. At the diagnosis of diabetes itself, the HbA1c was very high. Even though it came back to normal after the few years, their mortality rate remained high. And this is maybe because the marker for a long period of undiagnosed diabetes resulting in more complete beta cell secretory function at diagnosis and increased risk of mortality. And this is the second part of the diabetes and aging study, which was published 3 months ago. The legacy effect of type 2 diabetes again studied. I will just go through the conclusions. The study looked at the associations between duration and intensity of glycemic control immediately after diagnosis and long-term incidence of future diabetes complications and mortality. And it hypothesized that the metabolic memory exists in real-world populations also, and it begins as early as the first year after diabetes diagnosis and depends on the level of glycemic exposure. So HbA1c levels of more than 6.5 for the first year after diagnosis was associated with greater risk of future diabetic complications. HbA1c levels of more than 7 for the first year after diagnosis were associated with increased risk of mortality, and increasing periods of exposure to HbA1c levels more than 8 were associated with increased risk of microvascular events and mortality. The legacy effects still exist outside the trial populations and begins as early as the first year after diagnosis. So this is 3-month-old data. So finally, concluding, coming to the end, I will just highlight upon the latest study which we conducted in our hospital. It's still not published. The abstract has been sent for the IDF. And I will just highlight on the initial data. 424 patients who underwent coronary angioplasty or admitted with acute coronary syndrome in our hospital. Mean age was 60.8 years. 83% of patients had a history of hypertension. And only 17% of them had an LDL target less than 100 milligram per deciliter. And the angiogram report, if you can clearly see, more patients had dual vessel and triple vessel disease. And only 1/3 of the patients had single vessel disease. Multi-vessel disease was more common in patients, these patients. And longer hospital stay was seen in patients with diabetes, higher admission RBS, elderly patients, and females. And dual vessel disease and triple vessel disease was significantly higher in those with a history of diabetes, which we know from our textbooks. This was the most important slide here. As you can see, only 8% of the patients had an HbA1c of less than 5.7, which we considered as normal among the 424 patients. and 14% had pre-diabetes, and 28% were having an HbA1c between 6.5 to 8, and 39% had an HbA1c of more than 8. 11% did not undergo an HbA1c evaluation because their initial RBS was low. So again, highlighting that any patient admitted to the coronary care unit should undergo a glycemic evaluation, and HbA1c should be monitored. Among those with no history of diabetes, 25% had an HbA1c in the pre-diabetic range, and 34% had HbA1c more than 6.5. And only 1/3 were on statin, and HbA1c was not done in 23, as I said. Among those with a previous history of diabetes, almost 2/3 had an HbA1c of more than 8. Only 52% were on statin. Again, patients with diabetes who are being managed at the primary care level, no history of coronary syndrome, only half of them are on statin. And LDL was above 100 in almost 75%, where it should be below 100. And very high prevalence of multivessel disease in males. And there was statistically significant correlation with ST elevation MI in patients with statin who were not on statin, who had albuminuria, and who were smokers. And I was thinking, what was the importance of doing this study? Suddenly, when I was just scrolling through the Twitter yesterday, while yesterday 4 o'clock when I was sitting here, I just saw this post from Kamlesh Kunti, the practitioner in London. This was regarding one article which was published 5 days ago. This is actually the impact of elevated HbA1c on long-term mortality in presenting with acute myocardial infarction in daily practice, almost similar to what we did. Insights from a real-world prospective registry, which was published in the journal. So I'll just, I couldn't get the full text because it was a paid article. Just go through the results. You can see around 7,900 patients with acute MI were studied. 17% had diabetes previously. Among 60% had no diabetes, 34% had pre-diabetes, and 5% had newly diagnosed diabetes. The important thing to note is that both short-term and long-term mortality for both pre-diabetes as well as newly diagnosed diabetes was poor and comparable to non-patients with diabetes. And newly diagnosed diabetes was independently associated with long-term mortality, again showing the importance of early diagnosis and screening for diabetes in patients with acute coronary syndrome. So the study concluded that newly diagnosed or pre-diabetes was present in 1/3 of acute myocardial infarction patients. Actually, our study also showed almost the same results, which was associated with poor long-term clinical control. And newly diagnosed diabetes is an independent predictor for long-term mortality. And more attention to early detection of diabetic status and initiation of blood glucose lowering treatment is necessary. So my challenges remain my take-home messages. So you have to diagnose diabetes early, screen for the high-risk population, avoid clinical inertia, try to treat them aggressively to keep the HbA1c below 7, especially in the early part of the illness in younger patients. Make sure that the patient is having good medication adherence. Ensure regular follow-up visits. Screening for complications is very important. And very important, ensuring proper communication with the patient. So these are the 5 things which I consider as my challenges, and they remain my take-home message. There is evidence to show that just skipping the annual diabetic checkup itself doubles the mortality risk. So just making sure that your patient gets an HbA1c, microalbumin neuropathy, and a fundus screening once in a year, it itself can halve the mortality rate in your patients with diabetes. So these are the slides which I have been presenting, the final slides of my presentation for the last 5 years. I still keep them because I still believe that this should be done for all patients with diabetes. So we have to do the annual examination and make sure the patient is on regular follow-up. And you have to manage the patient with evidence-based medicine. These are the 3 parts of evidence-based medicine. Individual clinical expertise. You have to take into account the best available clinical evidence, and the patients, you have to take into consideration the patient's values and expectations. And this will bring out improved patient outcomes. Thank you all for the patient listening.
Any questions are invited?
Thank you, Dr. Prasanth, for highlighting our study also in the initial part. Actually, what you said is very relevant to our country, in our state especially, because the prevalence is alarmingly increasing. There was a study recently from Chennai also, where Dr. Ramendran has shown that the prevalence of diabetes in city is around 25% in the STRIDES study. Actually, rather than primary prevention is very important. That is preventing diabetes in persons who have risk factors. And primordial prevention is also very important as far as our state is concerned, because primordial prevention means preventing diabetes before the risk factors develop. That can be in the prenatal stage by preventing low birth weight and also high birth weight children by taking care of the mothers at the right time, and also by reducing the risk thereby. Thank you.
Yeah, I agree with you, sir. It should be primordial prevention more than primary prevention. Usually what I ask my patients to do is that when the patients come, when the father and mother comes, you have to ask their children about the status of their children. If both parents are diabetic, you have to ask whether their children are obese, and if they are obese, you have to tell them about the lifestyle modifications. Especially in females, if you see a 60-year-old female is coming with diabetes, if you ask them if they have a daughter, most of the time we can see that the daughter is already had a gestational diabetes. She might not have developed type 2 diabetes. She has developed a gestational diabetes. Again, that is again an alarm sign that that patient is at risk of developing diabetes in the future. So what you said is exactly right.
Sir, one more thing. Since you have mentioned the IDRS score, actually in all our OPs, actually we can have an IDRS score, because the diabetic patients will be coming with their children, with their son or daughter, and they will be remaining in our before the OPD for 1 or 2 hours. So they can have an IDRS scoring checkup, because the family history is very important. We have started a preventive clinic in our setup, in our OPD, where the persons can approach the preventive clinic and do their IDRS score, and if it is above 60, they can have a blood sugar checkup on that day or the next day.
Thank you, sir. Prevention is definitely better than cure, but if you can't catch there, let's at least catch them early. Thank you, sir, for that enlightening speech.